computer, so I'm hitting record so we can get started. People are going to be rolling in, but I'd say let's get going.
All right, sounds good. And if we have a small group, we have a small group, and it's even more interactive then, which is great. We're always happy to share. So, welcome everybody to another presentation in the Clinical Faculty Development Series 101 as part of the Alliance for Clinical Education. Today, my colleague and I are going to be speaking about simulation in medical education. My name's Elise Everett, and I'm a GYN oncologist at the University of Vermont, and I'm also the Assistant Dean for Medical Education and oversee the clerkship level. And I'm joined by my colleague, Dr. Cate Nicholas, who I'm going to allow her to introduce herself.
Hi, good afternoon, everyone. I'm Cate Nicholas. I'm the Director of Simulation Education and Operations at the Clinical Simulation Laboratory at the University of Vermont. We're the academic hub for all of simulation for the College of Medicine, College of Nursing, Health Sciences, and our Academic Medical Center. My background, I have a clinical background in ambulatory GYN and family planning as a physician assistant, and I've been involved with simulation education since the mid-90s. I got my start within SP methodology. And I'm really happy to be here today.
Excellent. Cate is the expert in this. I am just along for the ride. So here's our brief CME statements. You do get 1 hour of CME credit for participation, and we have no relevant financial disclosures. This is just part of a broader series, and just to orient you to that, we're trying to provide faculty development to a broader audience. So not just to clerkship directors or leaders in education, but really to clinicians and community physicians and others. So this is a 3-year series. There's 9 webinars a year. You get 1 hour of CME credit. It's the second Thursday of the month in general at 1 p.m. Eastern Standard. And we've tried to base the curriculum off of the guidebook for clerkship directors, which is the 5th edition. So we are seven seminars into this. So today is April of 2022, and you can see where we've been and where we're going for these 9 sessions this year as part of 101. And then next year we will be launching into 201, which are some more advanced topics. So thinking about health system science, interprofessional education, evaluation, some of the more complex topics. And then the 3rd year will be into the 301 series. And again, we're getting out into even more, bigger challenges. And things like accreditation and future career development and educational scholarship. So again, lots more to come, and we appreciate you coming today and hearing about simulation. Again, it's today our talk is I would say supplementary to the chapter in the guidebook. So, the guidebook chapter is a great place to start. We are not going to outline the chapter here today. We're really going to supplement the chapter, but we certainly want to give credit to the authors of this chapter. So our objectives today for the group are, we're going to define simulation as an educational strategy. We're going to talk about some frameworks and list some frameworks associated with simulation. We're going to apply instructional design process to creating simulation. And we're hopefully going to provide you with steps to create a safe and supporting learning environment in the realm of simulation at your institution. We're also going to list some elements of debriefing and the steps for creating an OSCE. So a lot to do in 50 to 60 minutes, but we hope to have this be a launching point for your thinking about how you bring simulation into your learning environment to your learners. And with that, I'm going to hand it over to Dr. Nicholas.
All right, thanks so much. This is a little different than what we usually do with simulation, which is much more interactive and relational. So we are unfortunately going to be kind of talking at you for the next 30, 40 minutes or so. But while we do that, I really want you to be thinking about how you see learning and teaching as an educator. I think of learning as what the students do. I think of teaching is what we do, but just because we taught it doesn't mean they learned it. So I always like to think about how do we make more room for learning by teaching less? And I know that doesn't sound quite right, but I think simulation moves us in that direction where we're giving them the experience, the space, and the place to make meaning of their experience, which is really what we're trying to do with all of our educational activities. Can we do the next slide, Elise?
Mm-hmm.
So we're going to start with just thinking about what is simulation. And really simply, it's an imitation of life. So it can imitate real patients, anatomic regions, clinical tasks, anything, situations, anything that you want to think of in which healthcare is provided. But what simulation for me really is, it's an educational strategy that if we are really thoughtful and careful, it can be truly transformational. And that transformation is not just for our learners, it can be for us as faculty, but at the end of the day, it can really be transformational for our patients. And that is really key here and what it's all about. So the other thing to think about is that simulation is practice without risk. And I know some of our learners don't always feel like it's risk-free because they feel like their integrity is on the line or their ego's on their line. But it really is a safe place, and the place where I invite our learners to make mistakes. This is the place to do it because here no one gets hurt. We can think about it. We can redo it again. We can time travel. We can move through what we're doing.
They're moving on their own, Kate.
They are. You might have to control them. I don't know why that's happening.
Okay.
So just flip back.
Right.
My apologies.
All right, there we go. Sorry.
That's okay. The good thing also about simulation is that it is learning and assessment on demand to meet the needs of the learners at the appropriate time. In the clinical setting, you can have this very interesting situation, a patient situation come in that you're managing and working through. And it might be a great level of learning for a third-year resident, but not so much for a first-year medical student. So simulation really allows you to tailor it to the need of the learner and the level of the learner. Okay, now you can go to the next slide, and I'm sorry. So we're going to talk about some theoretical frameworks about why simulation works. And it's important to know these because, and you can go to the next slide, sorry. Theoretical frameworks address how people learn. They are frameworks that we use to guide everything we do in terms of design. The important thing to remember in simulation, there's no one best theoretical framework, and we actually probably use a convergence of different theories as we move through it. And I'm going to share 3 that I use, but you might want to be thinking about what really speaks to you in simulation. You can go to the next slide. So one of the first ones that I really like and makes sense to me is the role of emotion in learning and the transfer of clinical skills and knowledge. And this was developed by McConnell and Eva. And basically knowledge is better recalled when people learn in a more highly activated state. Think back to some of your own learning and your training where you sat in a classroom or you sat around a table and you talk things through versus learning in the moment. Your heart's beating, your adrenaline's going, you tend to recall what you've learned there better. And that's what simulation can do. The key here, though, is that with those, as you see those rocks kind of balancing, is that you have to find the sweet spot. So you have to make it challenging enough that the learning takes place, but not so challenging that people are terrified and all they're thinking about is how do I get out of this versus learning. So it's finding that sweet spot. You can go to the next slide. The next one I like really a lot is Kurt Lewin's model, change model. It fits really quite nicely into how we do simulation. So his thinking is here, how do we get people to change? First, they have to understand that the status quo no longer works. that they need to rethink how they think about things or do things. I find this model works really well when we're working with more experienced participants. So someone who might be in the field for 20 or 30 years. How do you get folks like that to think about changing? Well, if it's working, they're not going to change. So providing them with an opportunity to do what they normally do or try something new and then figure out, wow, that didn't work the way I thought it might, really encourages people to think about relearning something, doing it differently, thinking about it differently. So in the simulation is an opportunity to unfreeze because you're like, well, that didn't work. The debriefing that occurs after the simulation is where some of the change takes place, where people really make meaning of what happened, think about it, reflect on it, and then think about how would I do that differently. The refreeze happens once you are in either in another simulation that's the same or in the clinical setting. So this unfreezing, changing, and refreezing all can happen within the context of a simulation. And the whole idea of people really doing this and changing the way they do things, you really have to be careful about people's ego here and the loss of ego identity as they perform in front of peers and maybe don't do exactly what they had hoped they would do. And how do we create an environment where that's not so threatening, but that's an opportunity? You can go next. And then cognitive load theory, which I think most people here probably have heard of and use it, really talks to us about how do people learn. We know so much more about how people learn than we used to know. And so it really helps us figure out how do people learn something new, put it into their short-term memory, put it into their long-term memory, and then retrieve it. Right? That's what this is about. It also talks about not overloading people. So doing it at a pace that makes sense. And this is really all about how do we design our simulation to the level of the learner? How do we limit the information that we're giving them, breaking it down into manageable chunks? How do we match the simulation methodology to the objectives? If you're talking about giving bad, sad news, we're not going to want to do that with a mannequin, even though the mannequin can talk. We're going to want to do that with a person with SP methodology. And remember that at all times, that debriefing is critical to learning. So we're going to move into looking at some of the next steps into creating some simulation-based education. But before we move forward a little bit, I just want to reference a few things we now have as tools here, which is we didn't have over the past 10 years or so. Both standards and best practice for simulation have been developed. That's been done by the International Nursing Association of Clinical and Simulation Learning, or NACSL. And best practices for SP educators in SP methodology has been developed by the Association for SP Educators. I really want to point these out as excellent references. Some of them, it's aspirational, but some of it is very much the kind of things we should be doing and how we should be doing them. And I think I'm going to turn it over to Elise to talk about the steps of a process in developing simulation.
Great. Thanks, Dr. Nicholas. So we're going to just spend the next few minutes sort of reviewing the overall simulation process, and we're going to talk briefly about each of these various steps, including instructional design, pre-briefing, briefing, the actual simulation, then debriefing, and then the evaluation of the program, so that we are really talking about this full cycle of continuous quality improvement. So to start with instructional design, this is really the work that we do before we have the learners in the simulation. So we start with, why are we doing this? And our work, we're really looking at gaps. Does the student have a knowledge gap, a skill gap? And we do a needs assessment to determine, what we need to, what gap do we need to fill with our simulation? So this should be related to a course or to a curriculum or to a process of improvement. The second thing we have to consider is, what is it that we want our learners to know, to do, or to act or behave? And these become the objectives that are going to direct everything else that we do. And these are the objectives that we're going to use for the debriefing, for the guided reflection. And you really want to have no more than 2 or 3 for any one simulation, because any more than this becomes fairly unmanageable. And then based on this, those objectives, we're going to very carefully select which type of simulation modality is going to help us reach those goals most successfully. And we're going to take into account really the learner, the level of the learner, and the required elements of fidelity, or how realistic does the physical environment need to be, or the simulation modality that we need to reach the goals of the simulation. Next, once we've decided on the simulation modality, the faculty start to work with the clinical sim lab with the simulation content expert, or SP educator. And these are people who are specially trained in SP methodology. And they will help you write an SP case, they will help with SP selection, they'll recruit SPs, and they will help you train them in anticipation of your upcoming simulation. They can also be available on the day of simulation to help with the process itself, or they can work with the simulation operations specialist, who's someone who's specifically trained in the mannequins or the task trainers. And these can also be an excellent resource for helping you create a scenario or to program the mannequin and run the simulation. So these are sort of your tech experts in the sim lab, if you will. And then on the day of the simulation, we have sim techs that are there to help set up and break down the simulation. And then you can work with the senior simulation specialist to schedule rooms and resources. You're also going to want to identify what material you're going to need for the pre-briefing and the briefing and the debriefing. And we're going to talk a little bit about those things in the upcoming slides. So you have lots of resources. You have your sim lab, you have your SP educator, you have your simulation ops specialist, and you have your SPs and all of these people. And it really does kind of take a village to do this successfully. And so you're going to work with that village to determine what kind of learner assessment you're going to do. How are you going to assess the learners in your simulation? Is it going to be an SP checklist and the SPs are going to give feedback? You want to think about how you're going to debrief your learners and select a debriefing strategy. You also want to think about creating a program evaluation. And we're going to talk a little bit about that later on, but we have a template in our sim center based on the Kirkpatrick model. That's what we use to evaluate the simulation programs that we run in our sim center at various different levels. And we'll review those 4 levels in a moment. And also think about what other faculty you're going to need to run your simulation. And often those faculty are going to need some faculty training. So one of the early mistakes I made was just having the faculty show up on the day of simulation. And it turns out that there needs to be a little bit of training that happens before. And then we always encourage doing a dry run to get out any kinks. And then some evaluation of those kinks and improvement before you actually run it with the actual learners. And this will help, decrease any anxiety, because when the learners are in the simulation, if there are some troubled areas, that will increase anxiety for the learner themselves. So that's all before the student gets there or the learner gets there. So pre-briefing is information or pre-learning that you're going to give to your group of learners prior to arriving at the simulation. So this is the goals and objectives of the simulation. This is reading or a video or some sort of pre-learning that you want them to do beforehand. You can do some basic orientation to the simulation environment. And you really want to give them very clear instructions and logistics about what time to show up, where to show up, what should they be wearing, should they have a cell phone, should they have a tablet, these kinds of things. And they all belong in the pre-briefing. Next, you're going to bring your learners in on the day of the simulation for the briefing. And so this is going to happen in the sim center right before you set off on your simulation. And again, it's a time to review the goals and objectives and see if the learners have any questions. And you're going to want to, again, review some of the logistics of what is the time going to look like, or the agenda going to be while they're in there in the sim center, in the simulation. And then most importantly, this is the time to set up the safe and supportive learning environment. And Dr. Nicholas is going to talk about some of the things we do to ensure that everyone in the learning environment feels safe and supported.
Thank you. Thanks, Elise. So this is really, if you think about, there's so much that goes into simulation, but there are a few things that are so key and really make simulation stand out from other types of educational experiences. So if we mean what we say to our learners about this is a safe place for you to be, you can come here, you can make a mistake, fall on your face, nobody gets hurt, and we're going to learn from it. Then there are things that we have to put into place to help make that happen. It really requires that we, as the faculty, remain curious about why a learner didn't do something we might have expected them to do or had hoped that they would do. And staying in that place of curiosity is really key, I think, to being a good educator in general, but certainly in simulation. You can go to the next slide. So there are some things that we talk about in the briefing before we begin with the students. And this concept of holding each other in high regard really comes from the Center for Medical Simulation. And this is an idea that we basically say, look, we know that you're smart. You wouldn't be here if you weren't. We know that to start with. We know that you care about your patients. And we know that you come to school to work every day to learn, and you plan always on doing your very best. We also know that best intentions are not always realized. And that can be because of fatigue, stress. I had a fight with my husband on the way to work. I got stuck behind traffic. I'm running late. I'm worried about a grant that I have. I'm worried about an exam coming up. There's always something that can get in the way. So we recognize that can happen in simulation. And so that if the learner doesn't do as well as they had hoped or what they had hoped, that it's something for us to get curious about and to learn from together what went well and what could be improved. This is no place for blame or shame. And so we really work hard at doing this. And this is difficult sometimes because we often know the participants well as learners or co-workers or in other ways. And we have these mental models that we hold. And mental models basically are based on our impressions. They're usually made quite quickly, and they can often be quite wrong. And so we really have to put our mental models aside, put our judgment. If you start hearing those judgment things coming up in your head about, oh, that learner, they're always whatever, fill in the blank. You really have to put them aside and try to get really curious about why something happened, whether it was great in simulation, like exceeded your expectations, or didn't meet the goals and objectives. It's staying curious is key. You can go to the next slide. The next thing we have to assure our learners of is that what happens in simulation stays in simulation. We call it the Vegas principle. And basically, it really means that we mean what we say. We're not going to talk about you on the lunch line. We're not going to talk what happened about in simulation in the lounge. We're not going to be thinking about, wow, that person, I can't believe, whatever. That doesn't happen. Everything that gets talked about in simulation starts at the beginning of your briefing and ends with your debriefing. And that's as far as it goes. We talk to our learners and our faculty about keeping confidential not only the performance but also the case, because we want everyone to who's going to be maybe using that case in the future to do their own best work. We don't ask people to sign a confidentiality form. We ask them to agree. It's kind of part of the honor code, but we do get people to sign a form that allows us to videotape if the videotape is something that the faculty would like to do. So we do get them to sign a consent there. You can go to the next slide. The next idea that we talk about, which is really important, is the fiction contract. So this was developed by a colleague, Peter Dijkman. He's a simulationist from Denmark. And this is really key. In the beginning of simulation, I think many of us used to say to our learners, it's just like real life. It's not just like real life. Yes, SPs are real people, but they are portraying another person's story. Yes, the mannequins are quite good, but they are not like real people. The heart sounds don't quite sound the same. The lung sounds not quite the same. Where you find different physical exam findings, not quite the same. So we want to just say that up front. Simulation's not real world. It's not often done in the same setting where you usually see patients. You don't always have access to all of your own, all the equipment you normally would. But we're going to do our best to create the most authentic experience we can. We're going to ask you to suspend reality a bit and agree to this fiction contract. And what we can guarantee you is that you're going to get a lot out of this. There's a lot that we can learn together. And the reason this is really important to name up front is oftentimes, especially if you have participants who did not do as well as they would expect themselves to do or hope they would do, they will often default to say, well, this isn't real. If it was in the real clinical setting, I never would have done that. We don't actually know if that's true or not, but it gets in the way of learning. And so we really want them to agree to this fiction contract. I get people to actually shake their heads yes. And then if we get into the debriefing and up comes that, well, it's not real, I remind them, remember we talked about the fiction contract? Let's think about what we can learn together. And if you really have a learner or participant who can't move past that, you're going to have to then go, well, let's talk about a clinical situation that might be similar to this in which you found yourself, and what can we learn from there? It doesn't really do us any good to fight with our participants about how real simulation is or not. They can get stuck there. The next slide is about reflection on action. We'd like to remind the learners that this is really all about reflection on action. So they're going to experience a simulation, participate in a simulation, but the learning, a lot of the learning is going to take place in that debrief period of time when you sit and you're having a conversation. And, you know, when we talk about debriefing is where the learning takes place, a kind of an average simulation, 10 to 15 minutes. An average debriefing should be twice as long. So take that into account when you do your planning. But I'd like to give them a heads up that we're going to ask you to go back during the debriefing and think about, how did you feel when this was going on? What were you thinking in that moment, so that they can really go back there and learn from what happened. You could go to the next slide. We like to talk about, I don't like the word trigger warnings. I don't have another word for it right now. But one of the things that we found is that no matter how experienced the participant, there could be something that goes on in a simulation that brings back a memory of an event, a real life event that was troublesome for them. Sometimes they haven't fully resolved it. Sometimes they don't remember it as well, but it can come back up again. And we want to make space for the learner, the participants, if that happens for them and they cannot continue in the simulation, that it's okay to give the facilitator a heads up and step out. We try to get them not to leave, but to check in with someone, because obviously something happened that was very upsetting, and we want to take care of them. This is all about that safe learning environment. Next slide. There's another group of people that we need to be thinking about in terms of creating a safe and supported both psychological and physical learning environment. And those are the humans who work in simulation. So those are our simulated standardized patients. Those are the people who are maybe confederates. A confederate is someone in a simulation who's in there to help the simulation move along. Or they're potentially portraying a family member, or they're portraying another member of the healthcare team. We just want to make sure that our faculty and our learners know that we're creating a safe workplace for them, that their participation is confidential as well, and we show them a great deal of respect. And so that's something that we often have to remind everyone of, because in a simulation, it can feel absolutely real, absolutely engaged emotionally. And we just want to make sure that we're not doing anything that we shouldn't be doing with someone, a human, in a simulation. So we're going to go on to talking about debriefing. So debriefing, I'm going to say I've been doing simulation for 20, 25 years. Debriefing is one of the hardest things we do. This is the opportunity for the learner to reflect on what was done, to make meaning of what was done, and to translate that into actual, how am I going to now be different in the clinical setting? The debriefing is all around your objectives, which is why I really like to limit the debriefing to no more than three objectives per simulation. And that is because debriefing is really hard work. It's a lot of work for the faculty person to stay curious, to be listening carefully to what the learners are saying, and to help that meaning making. And it's really hard for the learners to be doing that kind of genuine reflection and digging kind of deep into, why did I do that, or why didn't I do that, and to share that often in this group setting. So the debriefing is that's slide, great slide. The debriefing happens, you have your learning objectives, the simulation, and the debriefing. It's the difference between what happened with the learning objectives as what you hope people would do, to the simulation, which is what they actually did. And the debriefing's not just on what wasn't done, but it was also on what was done well, because it gives you an opportunity. Again, it's all about making this meaning of what happened, to go back and talk about, I noticed that during that simulation, and one of our objectives was closed loop communication, that when you asked for a chest tube tray, you said, Jim, can you give me that chest tube tray? And Jim's like, yes, Kate, I can give you that. How did you remember to do that? It's good. It got you the materials you needed to take care of that patient really quickly. How did you remember, in all of the chaos that was going on, to remember to do that? And it gives people a chance. It kind of cements the learning. So there is no one good debriefing technique that we found yet in any research that has been done. So there's lots of different ways to do this. I'm going to talk about kind of the 5 steps. You can go to the next slide, Elise. Kind of the 5 stages of debriefing that's common to all of them. And I'll spend a little bit of time talking about 3 different debriefing techniques that I like to use, that you can actually toggle back and forth in. The debriefing, again, it's something that will take you time to learn how to do, and learn how to do well. And one of the things that I recommend is that you find a community, a practice of people who are doing debriefing, and it can be locally or it can be nationally. And there's lots of ways to reach out where you can share different debriefing strategies and challenges and help each other get better. And I really recommend, as best you can, if you can film your debriefing and save it, that is something that someone like me or another person who has been doing this work can go over with you, watch with you, and give you some feedback on. So 5 stages of debriefing. The first one is the reaction phase. And basically, if you've done any sim at all, as you move from the sim to debriefing, the energy level in the room, especially if it's a team, is pretty high. People are like, you say, simulation over, we're going to move to debriefing. Whether you do your debriefing in the same room or you move to another space, I like to move to another space because it gives a chance for that people to have that reaction on the walk down the hallway or the walk to the next room, and it lets that emotional level come down a little bit. Also, by removing people from the simulation itself, sometimes they get a better chance to really reflect and kind of dig deeply. So the reaction phase basically is to say, thank you so much for participating in that simulation. How's everyone doing? And then you just let the energy go. People will be like, it was great, it was terrible, I can't believe I did such a bad job. That was, oh my goodness, there's a lot going on. And then you'll start to feel that energy level drop down again, right? When it gets to that place, you'll be able to think, okay, now we're ready to move to the next level. And so then you say, so let's talk about what happened during the simulation. Different faculty do this differently. Some faculty like to review it themselves. Some faculty like to ask the learners to review it. What happened from the beginning to the end? If it's a complex simulation, say it was a multi-trauma simulation and you're working with a big team, I equate that to sometimes being in that room with blind people and an elephant. Everybody has a different piece of it and part of it, and they didn't get the whole thing. So when that kind of thing happens, I like to go over it so that we get everybody on the same page. If it's a one-on-one or two-on-one situation, you can ask one of your learners to describe kind of what happened. Next slide.
Hold on.
Yep, no problem.
There we go.
There we go, no problem. And then we move into the facilitated reflection. So what we're going to do at this spot is you want to say, okay, we're going to talk about each of the objectives for our simulation, and we're going to go through them one at a time. So let's start with, and I'm just going to stay with, let's start with closed loop communication. And there's different ways to do this. So the three kind of different kinds of debriefing. One of them can be something which starts with the learner. It's a plus delta. What worked and what didn't work and why? And what would you do differently next time? So if we were going to do that for closed loop communication, I could say, okay, so closed loop communication was one of the objectives here. Can you all talk to me about what do you think worked well? Give me an example and talk to me about why it worked. And you have to hope that your learners are good at self-assessment, which we know historically learners are not very good at self-assessment, but this is a good place to start. So if they were able to say, well, I thought we did really well with closed loop communication when Jim asked me to call 911 and I responded back, I will call 911, it was a great example. That was good. Or they could say, well, you know, we didn't really use closed loop communication. I remember I asked for a chest tube and I had to ask for it 4 times. And then I finally realized I never asked a person, right? So you hope that they have some good skills here on what worked and what didn't work, and what they might do differently next time. If they didn't, if your group is like, well, we thought we did a great job, and you know that that wasn't quite it for you, you can move into something called, and this is a tough technique, it's called advocacy inquiry, or AI. And basically what you do with that is you share your observation. I'd like to talk about closed loop communication. Jim, I noticed that when you asked for the chest tube, you needed to ask for that chest tube 3 times because it was as if you were asking the room. You didn't ask anyone in particular. The reason that that can be a problem is that it took longer for you to get what you needed to perform that chest tube insertion, and that put the patient at risk a little bit more than that. Can you talk to me about what was happening for you right there? That's when you're getting them to reflect back and think about what was happening right there. And, you know, as the facilitator, you have to listen very carefully to what they're telling you, because they're going to give you something about their underlying reason for doing or not doing something. And then you move from there. The other third way is really direct feedback. I really think direct feedback should be isolated to when there's only one good way, not only one good way, one way only to do something, right? It really has to go with, you know, I noticed that you gave X milligrams of this particular medication in this way, and that will not really be adequate to treat the patient. The correct dosage is this, the correct way to give it is this, and this is why. It can't be, this kind of feedback can't be used when you have your way of doing it, but there's another good way of doing it, because all you do is get into a little battle about my way, your way. So the 3 kind of ways we talk about are plus delta, advocacy inquiry, which takes a lot of practice, and this direct feedback. It's there's a great article called Pearl's article that's written by Walter Epic and Adam Chang that I would refer you to on that. Once you go through whatever debriefing, whatever reflection you choose to, you've now also got a pretty good idea of where the gaps are. So, oh, we did pretty good on closed loop communication, but the algorithm for how to treat this particular problem, let's review. So you get to teach to the gaps, right? You're not teaching everything, you're teaching to where the gaps are. And then the final thing is this learner-centered takeaway, which is a time for, you could say, here's what we did today, here's what we learned today, but it's really up for the learner to tell you. So what I do is I ask each of the learners, can you share one thing that you learned today that you're going to use in the clinical setting? One thing you were reminded of that you're going to use in the clinical setting? And then I go around to each of the participants. And what's really great about this is it's also your first indicator of how effective you were. Was the simulation at the right level? Was your facilitation adequate to get people to reflect and make meaning of their experience? I've done this sometimes at a learner-centered takeaway and realize, okay, I missed the mark here. This is me. This is not about the learners. This is about me. And then before we let people go, we thank them very much, but we also ask them to please fill out a program evaluation before they go. Now, some people do that electronically. We do it right then and there because once people leave, I often think they're getting sucked back into the vortex of everything else that goes on in their life. And I really want to get their sense of how well that went for them and how we can make it better.
Great. I think I take over for to build on that. So in terms of program evaluation, which is really important for those of us who work in the Sim Center, we use the Kirkpatrick model, and it really is getting 4 different levels of evaluation of the simulation. And the first level is really the reaction from the participants. Did they like it? Did they find it favorable, engaging, relevant to their jobs? And then, so you might have 1 to 3 questions that sort of are at that level 1 if their reaction to it. And then you want to have some questions that are level 2 that are about, did they learn something from participating in your simulation? So did they get more knowledge or a certain skill or an attitude or increased confidence or something from participating in your simulation? And then you want to have some questions that relate to behavior, which is the 3rd level of the Kirkpatrick model. So can they apply what they learned in your simulation to their day-to-day work on the job? Can they take what they learned and then change their behavior and participate, apply it to their day-to-day work? And then lastly, the level 4, which you can't always achieve, but you always want to at least try to ask this hard question, which is, can this make a difference at the level of patient care? But so we can't always do that, but we should always aspire to do that. So can this simulation, can this educational intervention, help patient care, improve patient safety? And then we also ask our faculty who participate in the simulation about their experience with the simulation. And then we ask about, were the faculty and the simulation environment able to create the safe and supportive learning environment to make sure that we're meeting that goal as well. So about 2 weeks after you complete the simulation, we like to sit back down with the group of faculty and simulation experts who designed and ran the simulation to review what happened. So at this time you can review your program evaluation from the learners, from the faculty. You can review how the debriefing went and all of the sort of data that you collected. And then this is the time to, make improvements and then kind of continue in this cycle of continuous quality improvement. So it's a time to get the team back together, talk with all the stakeholders, look at what worked, what didn't, what do we need to change or improve for next time? And make sure this is all documented, and then make sure you use that document to move forward and not go back to the original way you did the simulation. So you want to always keep that version update and make sure you're using the most updated and improved version of the simulation. So lastly, to sort of close the out and then have some time for questions, is to think about simulation in assessment. So we think about simulation and as a teaching modality, but it's also very useful in assessment. And so these are just some examples of how we might think about using different simulation methodologies to assess different things. So certainly SPs are a great way to assess things like communication, history taking, physical exam. You can do clinical reasoning. You can have notes or documentation be reviewed, oral presentations. The SPs can be patients, and then you assess patient education. And we, in the time of COVID, have now added in telemedicine. How do our students do in a virtual environment as clinicians? And so these are all ways in which using SPs as patients, but also as the assessors, you can assess a student's activities in these realms. For things like procedures, task trainers are becoming more. There's so many neat things out there. Often they're very expensive as well, but you certainly, we have the technology to really allow learners to practice on task trainers to a level of mastery, because these trainers are just getting better and better. So for procedural things, often that's the right choice for assessment. And then of course the mannequins are also drastically improving in their realism. And they're a great methodology to use for like big simulations around acute events that don't happen very often. But when they do happen, you need to have a team that's functioning at a very high level. And so that's a great methodology to really assess things like teamwork and closed loop communication and processes and protocols that are in place in places like the ED or the ICU and things like that. So just tremendous opportunities to use simulation, both for learning, but also for assessment of learning. So some of the ways that a lot of places are doing this, and ourselves included, are increasing numbers of these objective structured clinical examinations, or OSCEs. And so, here at UVM, we have a lot of OSCEs within our curriculum, and they start early in the curriculum. And for our clerkships, at the end of every clerkship, there is an OSCE. This is a great way to, again, it's another observation and assessment of the learner. So we link our OSCEs to the goals and objectives of the course or clerkship. Our clerkship directors and course directors work very closely with the SPs to create and identify cases. And this is an ongoing process. So, certainly our cases evolve over time to accommodate, things like gender identity, or, we are up in Vermont, so we use SPs of color. We do things like, I just lost my train of thought. Sorry, it'll come to me. So all sorts of the cases just keep evolving as sort of our understanding of sort of what the students are seeing in the real world. We adapt our cases to those changes. So you can do a single case. Generally, we like to do multiple station exams, because the more stations, the more ability we have to differentiate among learners. We often link the OSCEs to certain competencies. So patient care competency, professionalism, interpersonal and communication skills, systems-based practice, and then establishing cut scores for each of those competencies, so that students have a target. And then if they don't meet the target, then we have the ability to bring the student back and do some additional training and then have them repeat a portion of the OSCE. And then of course our cases change because we want them to reflect actual clinical practice. So like in obstetrics and gynecology, we don't want to have all 6 of our cases be obstetric patients. We want to make sure that it really is a reflection of sort of the breadth of cases that they will see in the specialty. We also create rating forms, and these are generally SP checklists, and these are lists to behaviors that the students do. So it's very important that this is not just a gestalt, a feeling that you get about the student's abilities, that we are, watching and looking for behaviors and things that the student does, things that they say, skills that they perform, things that they do. And this then is reflected in the checklist. And then we also have sort of a global rating form as well. And our SPs are the most common raters or assessors for our students, but you can also have faculty and peers. I think the key here is that they all need to be trained to be assessors. And you have to kind of create the shared mental model so that everyone's in agreement, like what does a passing score look like? And then this requires, of course, a lot of recruitment and training of the SPs to portray the various cases and orienting them and training them to the assessment instrument. So it's a very labor-intensive process, but I think if you do it well, it's a very valuable process for our learners. So these are just some of the references that we used to put this talk together, and I have to give all the credit to Dr. Nicholas for that. And then we just want to say thank you for including us in this seminar, and we're going to have about 10 minutes or 7 minutes to answer any of your questions that you have for us. And so thank you. I'm hearing radio silence.
No.
Hi, Lou.
No, Dr. Pangaro has a question.
I have a question. Yeah, thanks. I spent 10 years as a chair and a year as a dean, so I'm interested in return on investment. Have you ever done, no, I'm serious about this.
No, I know.
Have you ever figured out what is the cost per student once you amortize the costs over an entire class?
Yeah.
I mean, the setup costs are a lot for the first OSCE, but once you put 50 or 100 or 150 patients through. So what is the cost of assessing certain kinds of skills, whether it's interviewing, breaking bad news? Do you have any data like that, or is that useful, do you find, in your work?
Yeah, I just, from us, there's some old data about cost, and the cost tends to go with certainly an SP methodology of utilizing SP methodology, meaning utilizing lay people who are trained to teach and assess versus having faculty, right? And if you take a look at the cost of training SP and having them do it versus faculty, there's a huge cost savings. And it really, I think that the kind of work stopped being done because there were so many articles out there that said SPs can teach and assess as well, if not better than, and it broke down, even all the way to rheumatologists. So I think some of that stopped being done. There is a conversation, certainly, and it got sidetracked by COVID, I'll have to tell you, but I was involved nationally, several different groups taking a look at return on investment. So people look at return on investment for certain things like central line, teaching central line to reduce bloodborne infections, and the cost, because as Elise said, some of these things are quite costly. But the savings, both in terms of kind of the morbidity and mortality of patients, we did a study in our own institution. It was one of the very first things we did. We saved the institution $7 million.
Wow.
But
I'm
that's
sure you got a, did you get a
we
bonus?
got a big fat check, Dr. Pingarrett. No, I'm kidding. It's not real money. We saved them from having to
I
spend
understand.
that.
Well, that's great. I have one other question.
Sure.
Well, I have you is, as you know, because of the step 2 CS going away, there's a lot of pressure on simulation centers and so forth. What pitfalls are you seeing? What problems are you seeing because of that? Are people trying to transfer work to you, or asking you to do things in a pass-fail summative way that you hadn't been previously asked to do? What are the pitfalls?
Yeah, I think that it can, we're an old program. We've been around for a really long time, and we had the benefit of the wisdom of an associate dean of medical education during a curriculum revision in the mid-90s. That simulation in the College of Medicine was integrated longitudinally, both for learning and assessment across the entire 4 years of the curriculum, including an end of level, before clinical, preclinical to clinical, and then a 12 station, very similar to step 2 CS exam for graduation. So we had the benefit of that was already kind of done. I mean, there's not a lot more that we could do in terms of getting into the curriculum. But I do think that what you're naming is happening nationally, where programs are looking at how do we do what we thought step 2 CS was doing for us. And so there's, I think there's lots of conversations going on nationally. The AAMC is heading up a project that I'm involved in. I think some others on this call maybe as well, of taking a look at how are we going to address this? How will we be able to say that our students are meeting the same competencies, right? And then there's the whole conversation about EPAs. So it's very fresh and conversation right now. Thanks.
Yeah. So Cate, I'm just going to pull some from the chat. So one question about defining excellence in sim, that we have a 2022 version in our resources. Do you happen to know which sections were significantly updated from an older copy?
Oh, I'm gonna say I only had one chapter in that copy, but I'm gonna say most of them. There's been a lot of work being done in sim. I think it's worth. I have to say I have a chapter in there, but it's an excellent resource, and I think it's been updated. It took 3-4 years to update it, so simulation's changing that rapidly. I would say it's probably a good resource, but get your library to buy it and check it out before you buy your own copy.
And then another question is, do you have any suggested must-reads for developing high fidelity sim cases?
Yeah, I'm not sure what you mean by high fidelity. So high fidelity for me is really about standardized patients, simulated patients being humans. I would say there are lots of them. There are lots of articles. I would go and take a look at MedEd Portal as a place and take a look at their simulation submissions and take a look at, they have a great tool, a great template for developing them. I would start there. I think that would be a good place.
You said the question.
Oh, I'm sorry, mannequin.
Mannequin now. Yep.
No, I would, Chris, I would go to MedEd Portal and take a look at their simulation, the mannequin-based work there. They developed a really great template that I think will help you develop it. MedEd Portal, yeah. And Chris, if you want to get in touch with me, please do, and I could try to hook you up with some other references. Happy to do that.
Mary Jane Pearson has her hand raised.
Yeah, I'm sorry. I'm trying to formulate my question, so I'm sorry if it's a little crazy. Hi, Elise. I haven't seen you in forever. We do have a sim center, and I'm an OB-GYN clerkship director. We do use low fidelity task trainers with students. we run into the issue, and you said a little bit about it, as far as the assessment when you're talking procedural skills. I seem to be butting up against, can we get sim techs or sim employees to test some of these simpler skills? Or must it be faculty only? Because you know all the demands on time. And I just wondered what everybody else does.
I think there are lots of opportunities in this realm. And so when we run a 2-week boot camp at the end of our, for our 4th year students, you know, we have all these great low fidelity simulations, but it's really hard to get faculty assessors. So just some ways to sort of you know, navigate that challenge. One is to have just a good checklist and have the student do a self-assessment, like, oh, I did that, I did not do that, I did that, I did not do that, or I did this really well and I did not do that really well. And so having the student do a self checklist is always good. And then we do a lot of peer checklists. So and again, then the students can learn from each other, which is often just really valuable. It gets away from the power dynamics and things like that. It's free. And then in terms of, you know, the challenges with the faculty, some of the ways we've been able to do this, particularly in like, say the interview simulations that we do, is to record it. So you can actually, you know, have the student use their iPhone, put it on a stand, you know, do whatever the low fidelity sim is, and then save that recording and then bundle all of that and give it all to a single faculty assessor. So send it to me myself and say, Elise, you know, will you look at these 15 students, you know, closing a wound? And then, you know, do a checklist assessment that way. You know, so those are just some of the like immediate fixes for that challenge. And then Cate can comment in terms of how others like a sim person could potentially help.
There have been some papers published about training lay people to be able to do some of that work. The other thing I know is that some people tap their retired physicians or advanced care clinicians to do some of this work. But I think the key here is, as Elise said, is having a very clear checklist on here are the steps that you must do and here's the way you must do them. Absolute. We developed that for our central line course. It started with, you know, 20 items and it got down to the 10 essentials that I got an anesthesiologist, a critical care doc, and a surgeon to agree on, which was the first miracle of my life and maybe the last one. But it's really key to have that done. And a lot of those are in the literature and are developed. So, but it is a tough one. You're right. It's a tough one. I saw some other questions.
Do you allow for free time in the sim lab for students to independently practice? I can't wait for your answer on this, Cate.
At least because Elise knows my answer is no.
We don't believe in independent practice.
No, here's the problem.
They learn bad habits.
If you're not following, if they're not getting immediate and feedback on doing something, sometimes the practice is practicing the wrong thing, or they're getting feedback from a friend who's telling them the wrong thing. I think that if we're going to use mastery level learning principles, they have to be there with whatever your expert is to give them feedback on that. So I'm not a fan unless they're working with one of our pieces of equipment that gives them feedback, right? Gives them haptic feedback, gives them feedback like our colonoscopy or endoscopy machine and some of our laparoscopy work where they're going to get feedback from the machine.
How do you control debriefing time?
Control it. Do you mean how do we not let it go beyond what we have scheduled it for? How do we it's about faculty development. So you have to have faculty development so people understand that there's a beginning, middle, and end of debriefing and how to manage that, how to manage the reflection and how to manage the group through that process. It's a faculty development issue.
Yeah, it's a lot of faculty training and a lot of faculty practice.
Yeah.
It's you feel like you're the medical student that can't extract yourself from the patient's room when they're talking, and so you really have to practice that skill.
It's a lot of facilitation skills, and knowing when to park something, keeping it related. That's why 3 objectives, no more than 3. You should be able to get through 3 objectives in that half-hour period of time.
And then a question about, do you feel the reliability is better if the skill assessment is done by faculty instead of standardized patients? And I guess I would answer that it depends. I think there are certain skills where a standardized patient is as good, if not better, and there might be other skills which are less amenable to a lay person. That said, anybody who is doing that assessment should be trained.
Right.
And you can train almost anybody to be an assessor of almost anything.
I think, ideally it's both worlds, because I think the standardized patient who's experiencing the encounter is the only one who can really reflect on a lot of what went on there in terms of communication skill. I've watched faculty watch other people doing physical exams and say that was great, and the SP comes out and says nowhere near having done a good physical exam. So this is where someplace I think for OSCEs, based on if it's kind of traditional OSCE, the SP is the better evaluator. In terms of clinical reasoning, this is where I think faculty has to come in. Clinical reasoning, the only person who can evaluate a clinical reasoning process is another clinician, a trained clinician on how to do this. The SP can't do that. But I think you want both. You get kind of the global gestalt from the faculty, understanding the whole thing, but you get that, checklist item. Did they ask this? Did they do that? Did they establish rapport? Those kind of thing. The SP is key here.
All right, we're out of time. So we're gonna have to bring this to a close. Thanks everyone for participating, and you most likely have already gotten the email that I sent out with the evaluation form. So
Thanks for the opportunity.
Yeah, thanks everyone.
thanks everyone.
Bye, Kathy.